So, as a depiction for the diseased Wiggers diagram and a stress condition, what we'll depict today is the aortic valve stenosis. And so you can see that much as we did last time, we will create our X and Y axes, which will enable us to draw everything out here. And of course, we will also make some key assumptions about what's going to be changing in some of these conditions. Starting off, we will start off with the core assumption that since it's compensated aortic valve stenosis, there's no change in stroke volume. When we look at changes in blood pressure, we assume that systemic blood pressure is relatively well maintained. Velocity is going to be increased, and that the amplitude is going to, the ECG could be increased due to hypertrophy. Now, when we look down at the heart sounds, again, stiffer ventricle now, probably going to have more S3 sounds. Similarly, we're going to have increases in ventricular thickness that relate to that. Coronary perfusion, we can assume that that's going to be reduced slightly due to increases in pressure during systole. And then finally, aortic dimensions, we could say, well, maybe it's going to be a slightly stiffer ventricle, but really, slightly stiffer aorta, but realistically, pretty comparable to an age-matched control. Now, when we start to draw our pressures here in our volumes, what you can see is that we're going to have to draw certainly our frame of reference for our isovolumic relaxation, isovolumic contraction areas. And then we're going to draw this atrial kick. Again, very comparable stroke volume between conditions, and essentially demonstrate that stroke volume 1 and normal is equal to stroke volume 2 in the aortic valve stenosis. Now, critically, when we start to look at the at the ventricular pressures, we'll see that now we get a dramatic increase in ventricular pressure because we've got to pump out through a higher resistance orifice. And then when we start to look at the pressures in aorta, of course, we've got to draw a broader gradient there because we've got aortic valve stenosis. We'll just shade that in there. When we look at atrial pressures, again, we compare down here. It's going to be a little bit stiffer in ventricles, so maybe we'll have a small increase in overall atrial pressure, and so that's that. Now, when we start to measure transvalvular velocity, very simple, very large increase in velocity due to that narrower orifice with a preserved stroke volume. And similarly with ECG, what we're going to be looking for is a significantly higher peak of the QRS complex and ventricular depolarization due to the hypertrophy. Looking at heart sounds, we're going to have pretty normal S1, S2 sounds. With that stiffer ventricle during the atrial kick, we might have an S3 sound manifesting. And again, that's about all I'd really anticipate people to depict here. Looking at ventricular thickness, we're going to, of course, have to depict a dramatic increase in ventricular thickness if we're hypothesizing that there's going to be an increase in hypertrophy here. And again, the way this is drawn, we can just shade this in and depict a dramatic increase in ventricular thickness with the hypertrophied ventricle. Again, with coronary perfusion, we're going to show a larger dip during systole due to that increase in pressure, and with the aortic stiffness comparable between groups. And there you have it, a full Wiggers diagram for aortic valve stenosis.